Good morning, everybody. Welcome to the Insight APSAD seminar series. First of all, we'd like to acknowledge the traditional owners of the land on which we're meeting today, and we'd like to pay our respects to elders past, present, and emerging. Today, it's my pleasure to introduce Staff Specialist in Addiction Medicine, Dr. Jim Finn, and he'll be talking about managing pain in opioid-dependent patients.
Thanks very much, Ben. It's great to be here. Because I've got two primary school age children, I'm not used to people actually listening to me, so thank you very much for being here. My talk today is pain in opioid-dependent patients, and that can be a tricky area because we've got to ponder a few points. The first is that pre-existing substance dependence doesn't preclude use of opioids for pain, but it does complicate that opioid use. Substance dependence virtually never arises organically or de novo during the treatment of acute pain or pain at the end of life. And substance dependence can interfere seriously with opioid treatment of chronic pain, and that's the one we usually have problems with. Both existing substance dependence and assessed risk of substance dependence warrant careful and structured opioid pain management. And even more than the pharmaceuticals, it's the careful structure that really improves patient care. Structured chronic opioid pain management can include use of written consent or agreements, urine testing, regular visits, and prescription pickups, and good communication between pharmacists and prescribers. Now, you can be concerned that in a known drug-dependent individual, their dependence will interfere with their pain treatment, particularly with opioids. And doctors are often concerned about addiction relapse when patients are given opioids in the medical setting. We also worry about drug interactions. How do we dose active users who are on an opioid treatment program or chronic opioids in an acute setting? And with drugs seeking for recreational use. Drug dependence does not preclude using addictive drugs during medical treatment for pain. It does introduce several complications and must be included when treating these patients. Now, this talk, as an anticipatory set, treats separately acute pain, pain at the end of life, and chronic pain. How do we define addiction? Now, we use the term substance dependence, certainly in DSM-4, as a medical term for what in general speech would be called addiction. Substance dependence describes patients who reach DSM-4 criteria for substance dependence, which is sometimes, and in DSM-5, is called addiction. Now, this includes drug tolerance, drug dependence, physical dependence that is, manifested as withdrawal when the drug is tapered or withdrawn, and at least one of the aberrant behaviours described by criteria. So when an addiction specialist or someone in the ADS field uses the term drug dependence, they're talking about more than a physical dependence. They're talking about that the patient is displaying aberrant social behaviours which are interfering with their life. Now, all patients treated chronically with opioids may demonstrate opioid tolerance and physical dependence, but unless they demonstrate opioid-seeking behaviours, they're not addicted or what we call psychologically dependent on the drug. And that's such as compulsive use and cravings. They do not meet the criteria for substance dependence, that's addiction. How do we treat acute pain? Now, during the Vietnam War, a lot of opioids were given to patients who had acute pain from being shot and things like that. They tended not to develop drug addiction. In fact, we even found that people who had a recreational opioid dependence when they were in Vietnam, most of them, like 99% of them, did not continue that when they were back in civilian life or even back in the United States. We do know that addiction virtually never develops de novo from opioid treatment of acute pain. In a survey 10 years ago, in that calendar year, 28 million units of dimorphine, which is heroin, was used in the United Kingdom, and virtually none of those patients in hospitals with acute pain developed a dependence. Dependence rarely develops when opioid use is structured and supervised, as it usually is in the acute pain setting. And this is particularly true statistically in treating post-operative or post-trauma pain. Acute hospital settings with post-operative and pre-operative pain, as long as the opioid use is of short duration, weeks rather than months, tends never to develop a dependence. Now, but when a patient is already has a current or past diagnosis of opioid dependence or even another substance dependence, if they're expressing a concern as to analgesia, it may be beneficial to avoid opioids or other addictive medicines, for example, benzodiazepines. Now, I have had patients who felt that they were completely abstinent from opioids. They had gone into hospital, had an acute exposure to opioids there, and they felt that they had then become dependent on opioids again. And that's probably psychological rather than physiological, and it's probably their own self-fulfilling prophecy. So we have to listen to those patients, and if they are alarmed, if we can, use other pain control modalities. But to put it simply, to treat acute pain in substance-dependent patients, treat the pain using whatever treatment best relieves the pain. This includes opioids as needed. Now, the acute pain setting is definitely the wrong setting for initiating or continuing active addiction treatment. And I've, in my private practice, had people actually say, would you come to the hospital where you want to get someone off their opioids immediately post-operatively? And I said, that's probably not the good idea while they're still in hospital. When known substance users are under care, plans should be made for addiction treatment after the acute pain episode. And for opioid-dependent patients, they will manifest tolerance as a resistance to opioids. So if you're on 80 milligrams of methadone a day and you go into a hospital for an operation, you're going to need more opioids rather than less. They may require heroic doses of opioids to induce analgesia, and they have a very narrow therapeutic window. And that means, unfortunately, that you may have to give them enough opioids to stop them breathing to relieve the pain. So they have such a narrow therapeutic window. If they have multi-years at high doses of opioids, they may still be experiencing pain when you're increasing the opioid and you leave, they can lose their airway. And for that reason, some of these patients will have to be in intensive care. There is a very narrow safety margin. We certainly find that in heroin-dependent people. The most people who are most likely to die from heroin overdoses are the older cohort who have been using for a very, very long time, because physically they have less respiratory reserve and they have this narrow window, the very narrow window between the dose of opioid which relieves their withdrawal and the dose of opioid which stops them breathing. Now, respiratory depression may exist despite inadequate analgesia. So quite obviously if the patient's unconscious, we have given them enough analgesia, but if they've got very, very slow breathing, they may still be complaining about pain. Now, it's thus advisable to maximise non-opioid analgesia. Now, these can be neuraxal blocks and regional anaesthesia, NSAIDs, and not forgetting paracetamol. And this should obviate the need for opioids as much as possible. Paracetamol is often forgotten. One of the receptors it works on is paracetamol receptors, which we only discovered in 2008. And I was at a meeting last night and there were 2 anaesthetists there and 2 paediatricians. And we were just discussing paracetamol, and the anaesthetist was saying, yes, that's the reason why if you give paracetamol as a preoperative thing to children, they're often sitting there giggling because their cannabinoid receptors have been, and none of us as a rule ever give paracetamol to children who are not in pain. The only people who tend to do that is anaesthetists prior to an operation. And the paediatricians were saying, oh, we thought that was just due to the sugar, but it's not, because children don't actually usually giggle that much on Fanta. It's the actual effect that the paracetamol has, and it is quite a potent pain reliever because it works on a non-opioid pathway. In palliative care, it's another setting where we don't really worry too much about addictions. We're not too concerned about addictions in acute care with a broken leg or a perioperative analgesia, and we're not that worried about addictive behaviour in most cases of palliative care. The absolute goal of end-of-life care is comfort for the patient, and even if addictive behaviours persist during terminal illness, we are going to tolerate them. And I can't emphasise that enough. We don't remove opioids from patients in palliative care, even if they're displaying aberrant behaviours, because, they really have a right to the opioids to treat their pain. Now, but it is quite rare for addictive behaviours to persist, because adjustments to terminal illness generally predominate. People are going through psychological acceptance and Kubler-Ross's stages, and all that's quite important to them. So they're not really focused so much on opioids, they're more focused on psychological adaptation. And it's never appropriate in the palliative care setting to withhold opioids because of a past or current history of substance dependence. Now, in these patients, there may be resistance to opioids requiring high doses, and these days as our opioid-dependent cohort on maintenance therapy has got older, I find that I've got more and more patients in their 60s and 70s as that cohort is getting coming through. There have been cases where some of my patients have had liver cancer post-Hep C treatment, and it can be challenging to treat these patients with palliative care, even though methadone itself and Viceptone are third level WHO approved medications for palliative care. Some palliative care physicians have more experience with them than others, and because they're such potent opioids, often the patient is on higher doses of opioids when they move into palliative care than they would be when they exit palliative care in any other cohort. And just as in acute patients, the use of non-opioid analgesia should be maximised to achieve the greatest comfort. Chronic pain is probably the greatest number of patients we've seen. It's very common in our community, but not all patients with chronic pain seek medical treatment for their pain, probably about 50%. And the factors that lead patients to seek help for their chronic pain are many, but in some cases may place the patients at particular risk of substance dependence. The personal characteristics that people have that make them more vulnerable to pain are also the personal characteristics that can make people more vulnerable to opioid dependence. Chronic pain plus the risk of substance dependence is a very, very, very common patient profile. What makes you more vulnerable? Well, if you have a personality disorder of any type, if you have anxiety and depression, if you have somatization disorder, if you have a history of childhood abuse, whether it's physical, sexual neglect, or emotional. So for this reason, we have to adopt universal precautions for all patients because we can't 100% predict which patients will develop dependence. I know 30 years ago I always used to almost laugh at the old representation of psychiatrists always opening a consult asking someone about their mother. But more and more we know that in an addiction assessment for a patient we have to ask about their childhood. In universal precautions that should be applied to all patients treated with opioids for chronic pain. And we've got to consider that every patient is at risk of developing an addiction more than a physical dependence. And I was talking one day to a colleague who's a GP, a very experienced GP, and he'd broken a leg and he was back at work and he was at work on crutches and it was quite a complicated skiing break causing him a lot of pain. And over a couple of weeks the pain went away and he was just having a really stressful day this day trying to keep up, hobbling around on crutches. And he took 2 endone that he'd been prescribed when he wasn't actually in pain. And then he went, oh my God, I've just taken that because I'm stressed. So he never took another one after that. But then he then understood why people can become dependent on opioids, because they treat not only physical but also emotional pain. All patients should be screened carefully and monitored before and during treatment. So screened before treatment, during treatment, and at different stages in the treatment. And that's the recommendation of Gurley and Hyatt, who are researchers in this area. Now, they talk about the 10 principles of universal precautions for pain. We need a diagnosis with an appropriate differential to start off with. We need a psychological assessment including a risk of addictive disorders, and that can be done by the assessing physician. We need informed consent, and while the book, The ABC of Pain, says this is verbal or written, in my opinion it should always be written. We need a treatment agreement, in my opinion that should be written, and we need a pre and post-intervention assessment of pain level and function. I can't just assume that if I'm starting a patient on an opioid, that will treat their pain. It may not. Opioids are not painkillers, they're pain-modifying drugs, because people have different genetic expression of different receptors. Some patients do not respond to opioids as well as others. So we have to assess the pain before and after the opioid intervention, because some people will fail a trial of opioids, not because they've become addicted to the opioid, because the opioid hasn't improved their pain. And more important, even than the patient's report of their pain level, is their degree of functionality. I've had a patient say, well, the opioid you put me on, which in his case was Suboxone, hasn't really changed my pain, still 5 out of 10 most days, but in describing his daily activity, he'd gone from being in bed all day except for 2 hours to being out of bed for 12 hours a day, which was a gross improvement in his life. So he had a huge improvement in function, and he'd increased his functionality until his pain level was the same that he was used to. So even more important than the patient's report of the pain level, if they're active, is their level of functionality. We need an appropriate trial of opioid therapy plus other medications, and we need a reassessment of the patient's pain score and the level of function. And in my personal view, for an active patient, I think the level of function has precedence over the pain score, unless the pain score has increased. And we've got to regularly assess the 4As, the big 4As of pain medicine, which is analgesia, activity, adverse reactions, and aberrant behaviour, always going through our mind. I have to treat a patient, he's actually on the opioid treatment program with methadone, and his concern at the moment, his very, very senior role in an accounting firm, and his concern is that his level of hyperhidrosis, his sweating on methadone, is so severe it's compromising his work, because people don't want to be in a room where he's giving a lecture if he's just, and a couple of times one of the even more senior partners has sent him home to get changed because his clothes are just saturated. And we might think that hyperhidrosis is not that severe a complication, but if you're in a very senior managerial role like that, it can really compromise your functionality at work. We've got to periodically review pain and comorbidity diagnoses, including addictive disorders, and documentation is the key. Everything should be absolutely documented, because in these fields there are no absolute answers for most people, and you can save a huge amount of time checking what's been trialled before. And we should apply for every patient we're putting on an opioid, other than on the opioid maintenance program, because the Section 100 opioids, we've already worked out that there is dependence, but if we're putting someone on an opioid maintenance program, we should do an assessment with an opioid risk tool. Now, an opioid risk tool, it's the tool, and there are many of these tools. This is the one I use, and it's for predicting aberrant behaviours in opioid treated patients, and the advantage of this tool, it's more accurate than an expert. So you can have a senior addiction physician taking a full history from the patient, assessing their risk of developing aberrant behaviours on opioids. They will be less accurate than this standardised risk tool. And if you have a look at what it does there, the scoring is different for females and males. The family history of substance abuse is somewhat important for females, it's very important for males. Illegal drugs, more important for females than alcohol, equally important for alcohol for males. Prescription drugs, equally important for each. So this is just their family. The personal history of substance abuse. For alcohol, it's equally important for males as their family history, but more important for female. For illegal drugs, it's more important, and it's more important for prescription drugs. Age, it's the middle years of life, 16 to 45, that are more important. And a history of pre-adolescent sexual abuse is a predictive factor for females and not at all for males. That goes against my clinical experience, which is probably why this risk tool is more accurate than me. And it's been tested again and again and again as a predictive tool. Psychological disease, if you've got attention deficit disorder, obsessive compulsive disorder, bipolar or schizophrenia, equally important across the genders. And depression, equally important across the genders. And if you look at that and score it, low risk is 0 to 3. There's 6% risk of aberrant behaviour. Very small, 94% chance there will be no aberrant behaviour. 4 to 7 is moderate, that's a 28% risk of aberrant behaviour. And greater than 8 is high risk, estimated 91% risk of aberrant behaviour. If now in a GP surgery that takes less than 2 minutes to complete, 30 seconds to score, probably they're averaging 2 minutes to go through that. That's a very short period of time to be assessing someone's risk for starting a medication such as a sustained release opioid, which could be life-changing for them with dependence. So it's really an essential thing to do. And for a registration on the opioid treatment program, we wouldn't use this because we're already registering on their opioids. But it's interesting because on a full assessment, you can fill in all those boxes yourself. Now, how accurate is it? Well, for those patients with a risk category of low, 99.4% did not display an aberrant behaviour. For those patients with a risk category of high, 40 out of 44, 90.9%, did display an aberrant behaviour. So it's a highly accurate instrument. And there are those 8 questions. But there are other opioid screening instruments available and they're validated as well. I use the opioid risk tool because it's the shortest and it has some of the highest sensitivity and specificity. And these are all available on the net. Now, if we use these instruments consistently for all patients prescribed opioids for chronic pain, it will help identify patients who would not otherwise reveal their substance use problem and provided the instruments are repeated on a regular basis. Now, believe it or not, the patient's family history might even change because their parents might develop a dependence they had not had, or their personal characteristics could change and their age can change. We can help identify new onset of substance dependence in patients who are developing iatrogenic, doctor-caused opioid dependence. And opioid agreements are very important. So an opioid agreement tends to take the size of an A4 page, which is a little bit too big and small to read up there. But we're used to opioid agreements when people start. the program, but they should all have essentially the same statements. The patient's agreeing to take the medication at the dose and frequency prescribed by the physician, and I agree not to increase the dose of opioid without first discussing it with my physician, and I will not request earlier prescription refills. So in my opinion, with an opioid agreement, while we should keep the original in file, the patient should be given a copy of their own opioid agreement, because over time they can forget what they've agreed to. I'll attend all reasonable appointments, treatments and consultations as requested by my physician. I agree to other pain consultation management strategies as necessary, because many patients have said to me on their opioid, no, it's my program, we'll do what I want and do it my way. And it doesn't actually work that way. It's a relationship, it's a prescriber and the prescribee. I understand that the common side effects of opioid therapy include nausea, constipation, sweating and itchiness of the skin. And drowsiness may occur when starting opioid therapy or increasing the dosage. And this is the important one, because this is what we often have trouble with. I do agree to refrain from driving a motor vehicle or operating dangerous machinery until such drowsiness disappears. And patients will come back to me and say, well, my doctor didn't explain to me that I could become physically dependent on opioids. And I'm sure their doctor did, but it's hard to remember everything in a consult. And we have to say that the patient understands long-term opioids to treat chronic pain may result in physical dependence. Suddenly decreasing or discontinuing the medication will lead to symptoms of opioid withdrawal. And the important thing is that the patient understands that these symptoms, though they can seem very severe, is very uncomfortable, but it's not life-threatening. And they should understand that there is a small risk, and it should be probably explained from the opioid risk tool how big their risk is, that they may become addicted to the opioids. And if they do become addicted, the physician may require further testing, such as hair, saliva or urine testing. And this is a very important one, because the patient, as well as agreeing to take the opioids as prescribed, also has to agree that taking other mood-modifying substances such as tranquilizers, sleeping pills, alcohol or illicit drugs can cause adverse effects, and they're agreeing to refrain from the use of all these substances without prior agreement from my physician. And good luck getting a physician to agree to high quantities of red wine on opioids. Now, I should check with my physician or pharmacist before taking other medications, including over-the-counter and herbal products. And I have to agree to be responsible for the secure storage of my medication at all times. Only 2 weeks ago, I learnt of a patient who had Suboxone in a secure storage, but his adult daughter obtained his key from where he had hidden and took too much. Thankfully, she ended up all right, but she took his dose allegedly for recreational purposes. Depending on the circumstances, lost medication may not be replaced until the next renewal date, so it's important patients store it safely. And this is a very important one. I consent to open communication between my doctor and any other health professionals involved in my pain management, such as pharmacists, other doctors, emergency departments. If I can't communicate with my colleagues, I can't treat the patient. So many patients wish to silo their medical care, and they have people for different things. Because opioid treatment covers such a dramatic area of someone's life, you can get one doctor prescribing opioids, another doctor prescribing benzos, a third doctor prescribing pregabalin. It's very important we have open communication. And I understand that if I break this agreement, my physician reserves the right to stop prescribing opioid medications for me, and that's our exit strategy. So if we no longer have the therapeutic relationship with the patient, we're prescribing, there's an agreement there that the physician can stop prescribing. and that should be dated, and it should be witnessed, and that's just the agreement whenever you're starting chronic, not for a very short course of endone perhaps, but if you're starting opioid treatment for chronic pain. Patients will often confuse pain with withdrawal symptoms. The clinical opioid withdrawal scale is a very useful scale working out whether the patient is experiencing withdrawal, and if they've got no withdrawal, their pain will not be withdrawal pain. It'll be rebound pain from the underlying pain condition. With drug testing, that's a little bit of a convoluted area. We've got to remember that fentanyl may only be detected in blood, not urine, so you can be injecting fentanyl, which is incredibly dangerous. One of my patients was injecting fentanyl, and he thought he was having trouble recognising time because he was losing several hours per day. And what he was actually doing, he found on his iPhone, when he put his iPhone on record, was turning blue after he'd injected fentanyl and gasping for air and almost dying. So he's having a near-death experience and having a blackout, and that actually stopped his fentanyl use. And he was someone who was using over the top of an opioid treatment program, which was probably quite effective in increasing his tolerance and saving his life. So it's a terrible drug outside of operating theatres. It's short-acting and very potent, but we may not be able to detect it in our patients who are using it. In THC, though, it can be detectable in urine for 6 weeks for a very heavy user. It's usually only detectable in saliva a couple of days post-use, but I do have one patient who's adamant that it takes 3 weeks to come out of his saliva because he has a testing kit at home. Urine testing tends to pick up 40% more aberrant drug use than could psychometric testing alone, which is pretty important. And some people are just good at fibbing. And I had one patient 5 years ago. I'd seen him the day before on 45 milligrams of methadone on the program for many years, as was his wife. Come in to see me the next day and say, right, everything I've told you in the last 4 years is untrue, and I've been using daily, injecting in my feet, and I've just been filling you. And I was fairly convinced that that gentleman was telling me the full truth. So just as some people are great at driving racing cars, some people are very good at telling untruths, and it's very hard to pick it up. It's hard to fill the urine testing. It's not 100%, but you can pick up 40% more aberrant drug use than could psychometric testing alone. And interpreting results can be complicated. The immunoassay test is not 100%. Any positive test should be confirmed by an extended US on the same sample. Extended UDSs are expensive, but they're the only definitive test. False positives are typically caused by ranitidine, which give a false positive test for amphetamines. And there are other false positives as well. And either presence or absence of a drug may be misleading. Now, if we talk about maintenance versus pain treatment, what do we do if substance dependence or addictive behaviour is seen to be active during opioid treatment of chronic pain? So the patient hasn't been addicted to opioids. Iatrogenically, we've made them dependent on opioids. And I was phoned only about 3 weeks ago by a colleague in a rural area, and he had a patient, and the patient, who was a 72-year-old lady, a grand dame around town, very respected in the community, for a month had been running amok, screaming, bashing on the pharmacy door. She had a chronic pain condition which was managed very well and stably for years, and had suddenly destabilised, and she was wailing and in terrible pain, and they thought she had a psychiatric condition, and the psychiatrist wasn't so sure, and they didn't know what to do with her pain. So she developed a substance dependence or addictive behaviour on treatment for her chronic back pain. Now, in this situation, the question arose, should opioid treatment be discontinued or modified? So that was our decision with this lady. Now, if the pain relief is questionable, well, she was using a week's worth of opioid over 2 days and had good pain relief on those 2 days. But if it's questionable pain relief, the best course may be to persuade the patient just to discontinue opioid pain treatment. And this works if they've only been on the opioid medication for a short period of time, weeks to months. In most cases, however, an addiction relapse is indicative of a serious addiction problem, and we have to do more than that. The serious addiction problem could be treated with opioid maintenance, at least in the case of prescription opioid or heroin dependence, and that's particularly in the case of injectors. Well, this 72-year-old lady was not an injector. She'd been on oxycodone for 10 years. Adequate pain relief could be maintained using maintenance opioids. It certainly can. Both Suboxone and methadone are very good for treating pain. And the best choices for maintenance treatment of addiction are methadone or buprenorphine, very good analgesics, but if we're not using them purely as a maintenance medication, which is usually once a day dosing, we may split the dose and give them more frequently. Buprenorphine has a ceiling effect, very good pain up to the ceiling effect. A pain physician will often prescribe up to 2 milligrams a day of buprenorphine. We typically prescribe up to 32 milligrams a day of buprenorphine, so 16 times the dose of a pain physician. Methadone's lack of a ceiling dose therefore makes it more useful in severe pain. And case management is essential in opioid maintenance, so we have case managers in the program who deal with the patients individually because they require more contact than other patients in the community. And initially, daily presentations to pharmacies are useful. So what did I do with the lady who, I never saw her myself, I was just offering phone advice to the lady who was in the rural community and actually running amok. The family were very distressed by her behaviour because they'd never seen her behave like this. The only thing we had to do to restore her to full functionality is to put her on daily dosing at the pharmacy, because that way she couldn't use her medication early. Her pain went down because she was behaving like she was, because for quite a long period of time she was in great distressing pain when she'd used her medication too early, and she was having both withdrawal and rebound pain. So by changing her from weekly pickups to daily pickups, all the aberrant behaviour almost magically disappeared. It disappeared within 2 days. And the doctors I was consulting were shocked by the quick change in behaviour, and that was because she was no longer in distress, worried about where her next opioid dose was coming from. And that's essential, giving someone security in life. So daily dosing, far from being an imposition in people, can actually give them great security and reduce anxiety if it's necessary. So in conclusion, opioid dependence complicates pain treatment in several ways, particularly when opioids are needed. In the case of acute pain and pain at the end of life, possible drug interactions and opioid tolerance rather than addictive behaviours are our concerns. And for patients with chronic pain, we've got to worry about addiction re-emerging, the risk of new onset opioid addiction or iatrogenic addiction, which we can cause particularly if we're giving too much opioid for the pain. So if you're giving enough opioid to relieve the pain so the patient's happy and comfortable, you're probably less likely to do that. But if you dose them above that level, they can then become dependent psychologically. We've got to worry about the risk of drug diversion. Methadone and morphine sell for about $1 a milligram. And we've also got to be aware that claims that medication is non-addictive. That's a children's cough mixture for heroin, and it used to be for bronchitis, and it used to be described as non-addictive. A good friend I went through school with went through severe withdrawals when he was 8 because his parents went overseas for a week, and he used to be, in those days they prescribed Volcadine for asthma, and he used to have severe asthma, but he'd drink 2 bottles of Volcadine a day, kept him calm. And his parents would just have a fridge full, and his grandma came over to look after him for a week. On the second day, looked and went, "Oh, this has got opioid in it," and just poured it all down the sink. By the time his parents got home a week later, he was no longer addicted to Volcadine, but he was a far less happy boy. Who's ever seen the 10? Is it 10? 10 drugs is the one that's not there, isn't it?
No, it's in there.
It's the one that's there. Has anyone seen the 10 drug video in German? Oh, I thought everyone would have. Could we play it?
10 Drogen, die Sie nicht nehmen sollten, wenn Sie Auto fahren. Stopp. Rechts oder links, rechts oder links, rechts oder links, rechts oder links. Mir doch egal, Hauptsache Vollgas. Alle Autos, alle Ampeln. Weg, weg, weg.
So modern life's very, very complicated, so I'm amazed that some people have any degree of functionality with substances in it. So there's only 2 books I've ever coveted in my life, and this is one I actually own, and it's Professor Jane Ballantyne. She's an American physician, and she has chapter 11 of the ABC of Pain by the BMJ, and it's the best book on pain I've ever come across. It's absolutely wonderful. Gourlay and Hyatt talk about universal precautions in pain medicine and a rational approach to the management of chronic pain. And Webster, predicting aberrant behaviours in opioid treatment patients. So let's have a look at a case study. Mr. X is 49. He's got a remote history of heroin use 5 years ago. Was an on again and off again user for the 10 years before this. Perhaps not every day. In that 10 years, probably for a week here, a month there, and then he'd come off it again. He's maintained on 50 milligrams of methadone daily, not a high dose for opioid replacement therapy. And he's had a recent diagnosis of throat cancer, and he's on chemo and radiotherapy. He's also a non-smoker, never smoked, but he developed throat cancer. And what are we going to do for his pain relief? Any ideas? We could increase his methadone. We could definitely increase his methadone. That's one way to do it. One of the difficulties is that his actual radiotherapy is going to go on for 6 months. So increasing his methadone, and it's also bursts of radiotherapy. So they do radiotherapy, then you recover, your throat heals over the next 3 or 4 weeks, then you probably have a month off the radiotherapy, and then another bout with the radiation, and you've got a great deal of pain from localised swelling. So for constant pain, increasing the methadone would be the right way to go. But this fellow was having pulse radiotherapy intermittently over, I think it was actually longer than 6 months, closer to 10. So that would be one way to do it. Sorry?
Could you use endone as a breakthrough pain on injury?
Yeah, you could use endone as a breakthrough pain, and the interesting thing about that, the problem with that is, even though I said 50 milligrams of methadone is not a particularly high dose on QITP, it's probably enough that 5 milligrams of endone isn't going to do a lot. And the breakthrough pain isn't breakthrough pain from a chronic condition, it's post-treatment pain from the radiation, so it's a little bit more complicated. And while endone's going to last 6 hours, and this gentleman's going to have pain for a week or two, so it's quite complicated. Oh, I'll go back. So what they ended up doing, the radiation oncologists, they ended up giving him Capanol on top, and quite a bit. So they'd give him 2 weeks of Capanol after his radiation treatment, and then stop it. And the 2 weeks of the Capanol wasn't enough to make him dependent on the Capanol on top of the methadone, but it was enough to relieve his pain. So then he'd have, every 6 weeks he'd get the treatment, then he'd have the Capanol, which was for 2 weeks, then go off the Capanol. And they would write me letters going, this incredibly happy man. He'd be just sitting there beaming because he really, really liked opioids. And he was really, really happy when they give him opioids, and he took them as prescribed orally, but he just said he'd have, he'd have pain following the treatment, but they gave him quite a lot of Capanol, and he was a very happy man. And then he'd come off, and he was actually used to look forward to his radiation treatment because of the Capanol, and he did not destabilise at all, and years after the treatment is still in the program, still on the same methadone dose with a highly functional life.
With head and neck patients, often they can't tolerate anything orally. What would we have done then if we couldn't have the Capanol, the slow release Capanol tablet?
If he couldn't have the slow release Capanol, that then becomes a difficult situation because you don't want to use a fentanyl patch. Norspan patch isn't going to do it. So that might be a situation where you have to treat the patient's pain as an inpatient.
Yeah, and I worked in head and neck for many years, and it was an ongoing problem.
Yep.
Yeah, we could never get on top of it. Ever.
I mean, with this gentleman with Zofran he was able to tolerate, it would have become more complicated if not, because we don't want to give him non-oral opioids, parenteral opioids with a significant injection history. And we can't give a patch because he's would very much know how to convert a fentanyl patch into injectable fentanyl. So that would have been tricky. But he probably would have had to require an admission. But we were lucky. Oh, sorry, any further questions about case study 1 before I go on? Okay, if we go to case study 2. This gentleman is 28 years old. He's a past heroin user, a bit taller than me. He's 192 centimetres tall. He's a frequent weekly LSD user, BMI of 35. Now, he at a young age, 28, developed metastatic melanoma causing paraplegia. And prior to the diagnosis of melanoma at a very young age, was stabilised on methadone 90 milligrams. What do we do for this gentleman? It's a hard one. So he's in hospital, he can't walk, the melanoma's got into his spine. A very, very sad case.
It'd be a case of palliative care.
Yep, the palliative care took over. He was under a good palliative care team. He first was on, before he went to palliative care, he was under the care of the pain physicians, and it was at a period of time when I used to have an attachment, an educational attachment to the pain clinic, so I got to follow them both at Melaleuca and Inside, and they were doing all the right things. They were giving him ketamine as well for his pain, as well as they increased his methadone. They split his methadone dosing, all appropriate. They gave him ketamine for the pain, and I still remember when going on the ward round when they asked him, how was the ketamine responding? He said, it really helps my pain. I give it 6 out of 10. He said, I don't use a lot of it because I find LSD gives me 10 out of 10 pain relief. And so they were in I've never seen so many pain physicians look so shocked. But he remained on ketamine when he was taking it, and he eventually went into palliative care into a hospice They did say he was displaying drug-seeking behaviour but not opioid-seeking behaviour, and on higher doses of methadone split did quite well. Now, psychologically, his concerns and what he would be teary in life would be poor ways in which he treated people in his life. Now, he'd never been an abusive person, but he said he might have powdered down heroin or something in a drug deal, which he was then having remorsefulness towards the end of his life. So his concerns were not poor me, it's that I should have treated other people better. So going through those Kubler-Ross phases, he was dealing with all of that. The hospice did contact me and say they were having trouble stopping his access to other medications, and he passed away in the middle of his 29th year, but he was using LSD from street sources also to deal with his pain. Case study 3. Miss Z is 29, she's stabilised on Suboxone 16 milligram. She hasn't used heroin for an entire year. She had a motor vehicle accident because this lady likes benzodiazepines, was driving along, and driving studies show only a partial tolerance to benzodiazepines is developed even on a stable dose. So on high doses or binge use, it's quite difficult to drive. It's like being drunk. She fractured a femur. This was also when I was at the Royal Brisbane on a pain attachment. I was only doing half a day a week, but she came into the hospital while I was there and had her fractured femur. There's what we did then and what we would do now, and there are two different things. I can tell you what we did then is we stopped the Suboxone, put her on, this is the pain team, put her on IV morphine in her case to deal with her pain, and we might do something slightly different now. Could anyone tell me?
Maybe increase the Suboxone, but you'd also have to deal with a benzo withdrawal.
Yeah, so you've got a little bit of time with benzo withdrawal. Her major problem was diazepam, so it's got a half-life of, on average, of 48 hours. There's 5 half-lives before it's out of your system. So we've got some time. We can put her on a benzo withdrawal scale. We could increase her Suboxone, but the other thing we could do is just keep her on Suboxone, but split a dose 4 times a day or twice a day, and give her other opioids over the top as necessary to treat her pain. She ended up doing fairly well, stopping the Suboxone on the morphine, but the Gold Coast Hospital shows it's better to keep the Suboxone going, split it, and there's less opioid use overall.
What type of other opioid would you use on top of Suboxone? I can allow for the fact that Suboxone binds to the receptor so much. You'd have to use a fair whack to try and...
Yeah, so what they first tried is on the 16 of Suboxone was morphine, got moderate effect. They then swapped to fentanyl and got a much better effect because the fentanyl itself has quite a high affinity for the opioid receptor. Yeah. So fentanyl, we don't broadcast it, but it can be used over the top of Suboxone. Case study 4. Mr. Y, 62. He was on Physeptone 30 milligrams BDPO. Now he was under the palliative care team with liver cancer for 5 years, and very embarrassing to the palliative care team, he was discharged alive from the palliative care team. He just was not getting any worse. And they were having difficulty treating him because after 5 years of quite an amount of Physeptone, they thought he was showing drug-seeking behaviour and thought he should be best under an addiction team. So you very rarely get a palliative care team and say, we're discharging you a live patient to deal with. So what are we going to do with this gentleman? Yep, so we can try him a methadone. Yeah, and even though he's doesn't drive himself, we initially put him on methadone daily dosing, and from memory we get him to go in and dose once a day and take the other half as a pickup dose, and he's remained much stable because we're harder to heavy than the poor palliative care nurses were, so that they're not used to the palliative care patients living long enough to develop an iatrogenic addiction, and it's harder for them to deal with than us. And while phiseptone and methadone are essentially the same drug, the restriction and rigour around methadone on us as prescribers gives us safety. And I thought I'd let you guys in the last minute fire a question at me. Yes, Maria.
No, I was just wondering, for people who are actually on palliation, and we know that, some of our patients are actually quite more hyperalgesic than normal. I was just wondering, why can't we use methadone as an IV, put it in a driver, for palliation?
Why can't we use methadone IV?
For palliation,
yeah,
put
so,
in a driver.
My understanding of that is it's used internationally, IV, but it's not common use in Australia. So it's not TGA approved. If you look up MIMS, there's no IV methadone, but certainly internationally it has been used that way. The reason methadone fell out of favour for in-hospital use is because it's got such a long half-life. If you give someone a little bit too much morphine, you're going to notice, and it won't build up if you BD dosing. But if you wake up a patient to give them methadone and it's building up over the days, because of the long half-life in an acute care setting, it's a more dangerous drug.
No, I'm talking about end-of-life cares.
Sorry?
End-of-life cares.
Your end-of-life care, yes, certainly. So, yeah, I understand it, in my opinion, would be a very useful drug given that way. We've had a patient in recently in Prince Charles who, when I was first phoned up about, there was a slight miscommunication. I thought they were being given it as a syringe driver, so I popped over there, but they were actually being given it in a nasogastric tube. But pharmacologically, there's no reason it couldn't be done. I just think my understanding is it's not TGA approved in Australia for that reason. Jeremy might have more information of that, but certainly internationally it's used that way. The same difficulty arises because of the half-life, so you have to titrate it fairly carefully. Jeremy, are you aware of any cases of IV methadone being used in Australia?
In ICU, I think there have been occasions when it's been used where someone's been on the program and nil by mouth, and it's hard to find another opioid that does the job. I used to say it was equivalent, a dose milligram per milligram, but I've since read that you should drop the dose by about 20% if you're using someone with long-term oral methadone switching into IV.
What percent, sorry?
20%.
20%, yes. The last case I heard of IV methadone being used was on a neonate with post-operatively for tetralogy of Fallot, and that was about 5 years ago on a friend's daughter who did very well, and they eventually used morphine to get her off the methadone. Yes, George.
When did they drop the IV methadone from the TGA?
I just know it's not listed in MIMS. I'd have to check the approval on the TGA, and of course there's the standard drug list, which is different, which I haven't checked recently.
Because in the past we used to have, within the clinic, we used to have a minor group of people who were on IV medication as a maintenance. Was dispensed on a daily basis at the clinic.
Well, as many of my patients have demonstrated, methadone can be used IV, and certainly, and certainly internationally, it's used in hospitals IV. I just don't feel it's in common use here, and I think that's largely because it's not that often a used drug.
Well, yeah, I think it was the 70s, 80s, maybe to the end of the 90s that sort of last of those people died out.
Yep. There was a gentleman recently who'd had a total colectomy and had, after the jejunum, no GIT whatsoever. It's not a rectum or anything, and he was on oral methadone and developed hyperemesis and went into hospital at the Royal. And when he originally developed the hyperemesis, I said, if he has a lower GIT, I'm not worried. We can still dose him. And they said he's got no lower GIT. So my understanding is they did use IV methadone for him. Thank you very much for your time today.